On this episode, we're going to be discussing the clinical assessment and evaluation for the scoliotic patient. And we have some basics that we have to go with as far as evaluation and clinical assessment. Of course, number one is the height and weight of the patient. We put this on a follow-up chart or a diary chart for following visits. Then we have the basics Adams test. And the setting for the Adams test is very simple. It's just, if you all review the Adams test on YouTube channel or whatever, just make sure the knees are straight forward, it's not bended. The arms are hanging down to the gravity, not holding anything, all in like passive mood. And it's straight bent forward, and only exception to this if the patient has like a pelvic obliquity or leg discrepancies and stuff, we could do the Adams test in a seating position. We allow the patient to sit on a stool or some kind of chair, and we let him bend forward, so this will take out the effect of the pelvic obliquity or pelvic discrepancies or leg discrepancies when we do the test. And of course we do the scoliometer reading, and we all know that it's critical between 5 and 7 degrees. More than 7 degrees, it's a pure indication for X-ray evaluation or X-ray prescription for this particular patient. Then we check on the hump. We look at the hump, we locate the hump, we touch the hump in a different rotation movements for the patient, lateral bending, forward bending. We see the nature of the hump. Is it solid hump? Is it retractable hump? Like, does it go away? Does it stay? Does it increase with certain movement to evaluate the hump? And also by doing lateral bending for the patient trunk, we can determine the flexibility or rigidity of this particular hump or this particular, and also for the curvature. ATR and ATI, that's also some tools, which is anterior trunk rotation, that we could also measure. And after we finish this basic stuff, we can go through the surface assessment scale or topography for the body. One of the most important thing is a trace system, where you can find it in a lot of sites actually, trace evaluation or trace assessment. We evaluate the shoulder balance, the scapula, along with the hemothorax and the waist, and we give grades for each one. And this trace scale is from 0 to 12, is very important not only in diagnosis but also in a follow-up. Then we have another topographic tools like the anterior trunk symmetry index, like what we see here on the slides right there, and also posterior trunk symmetry index too. And all these tools together will allow us to determine and to evaluate the presence of the curvature and the postural effect of it. That's all done just by inspection of the patient, and it's all non-invasive. And that's a way before we determine the X-ray thing. Also, one of the most important thing is we have to clinically assess the hypermobility of the joint and the joint laxity. How's this patient's joints and soft tissue are behaving, or does he have any accompanying syndrome that is hidden and also could be determined by the joint laxity testing. And of course, as we said before, we have the supine and prone, flexibility, rigidity assessment, because all these tools together will allow us to put us on the right direction to prescribe when it comes to exercise, to bracing, to managing this particular case. Those are the main, or our landmark, that we will follow to do the right thing for the patient. One more thing is a balance test. Balance test, there's a very famous, um, as you guys know, the Romberg test, the Vokoda, Hitchhake nystagmus, semicircular canal assessments. All these different tests will allow us to figure how this particular patient, how his CNS working, how his vestibular system working, how does the posture has been affected, does he have any hidden neurological things that we could investigate more. Those are the very basic, simple, done in the clinic within few minutes, that you can determine the necessity of the further neurological examination. And also the neurological examination as a strength of the muscle strength, sensibility, somatomotor stuff, deep tendon reflexes, abdominal reflexes, the superficial abdominal reflexes precisely, Papinetsky sign. This is done to determine is there an upper motor neuron lesion, lower motor neuron lesion, posture, as we said, the posture analysis and vestibular assessment. And there's two couple nerves, very important, two couple cranial nerves has to be tested to cranial nerves 3 and 6. Those are the main nerves for vestibular function or dysfunction that we can find in certain patients. Afterwards, we arrive to after we add all this information together and we have the indication to do the X-ray. This is literally the gold standard to label a patient with diagnosis of scoliosis. As we know, and we repeat again and again, we do the full spine P2A and lateral view. That's gold standard. This is the main basic stuff that you will do in the first visit, in the follow-up visit, and through the management trip. If you prescribe bracing, exercise, some nutritional advices, the follow-up, and there's rule and guidance for the X-ray every 6 months, every 12 months. It depends a lot about the case-by-case evaluation. And of course, we have to go by the standard precaution for the X-ray and the guidelines. That's everywhere in all the medical field. Some modern evaluation tool does exist and give us an opportunity to nail the cause and the pure diagnosis for the case we have, like EOS, the CT, the MRI, the 3D CT, the 3D ultrasound, the digital postural assessment. Not only that this will allow, we're going to discuss all this in detail in the next video, but not only this will allow us to have the pure diagnosis, or is it syndromatic, is it neurological, is it congenital, is whatever kind of scoliosis, but this has a very critical role in prescription and in management for the supportive treatment before we arrive to a neurosurgical. Of course, it's also golden standard in the surgical intervention, but for us, we do also this stuff to determine what kind of exercise, what kind of bracing manufacturing, bracing fitting, what's the pros and cons for such cases, 1, 2, 3. I mean, all these details adds up to put you in the right track for the right patient and the right management. And this is My last slide here is, as we mentioned before, this channel for all scoliotic healthcare provider, be TMD, DCs, orthotists, surgeon, nurses, and also the most important, the scoliotic patient and his family. It just fill up the gaps among different scoliosis clinicians through the scientific literature and research paper. My name is Wael Abdullah. I'm a medical doctor and a doctor of chiropractic, and also obtaining a master's degree on the scoliosis treatment or alternative conservative treatment on the Italian Institute. Thank you for joining us, and hopefully we'll see you in the next episode. Thank you.